We are ready to begin.
Hey, hello. Welcome to our webinar this afternoon. Today we're going to be talking about treatment of opioid use disorder in pregnancy. Our presenter today is Dr. Ritu Bhatnagar from University of Wisconsin-Madison. They did their medical school at University Iowa Carver College of Medicine, also receiving an MPH. Did their psychiatry residency and addiction psychiatry fellowship at UW-Madison. After a decade working in addiction treatment settings, they are now Associate Director of Psychiatric Services at University Health Services at the University of Wisconsin. They are also a clinical professor at the University of Wisconsin School of Medicine and Public Health Department of Psychiatry, where they hope to share their perspective of the importance of treating the many parts of an individual's life which influence their mental health beyond the presenting complaint. They are also the principal investigator for Wisconsin Voices for Recovery. Dr. Bhatnagar is president of the Wisconsin Society of Addiction Medicine and serves on the Medicaid Advisory Committee, the Ending Deaths of Despair Task Force, and the Wisconsin Alcohol Policy Report. The objectives for today's talk are, at the conclusion, the participant will be able to, 1, define trauma-informed care and describe how this approach relates to management of pregnant persons with substance use disorder. 2, describe the challenges and opportunities for treatment of substance use disorder in pregnancy. And 3, differentiate between the medication management options for pregnant persons with opioid use disorder. So our diversity statement, IAFP will support diversity, equity, and inclusion in all of its forms, recognizing that these require an enduring commitment that must find full expression in our organizational culture, values, activities, and behaviors. A little bit of housekeeping. Please keep yourselves in listen-only mode, or we will keep you in listen-only mode. If you have a question, please make sure to enter it in the chat feature, and I will read these at the end of the presentation. We are making sure to keep enough time for that. The presentation is being recorded. You should see that at the top of your screen that the record is on. All discussions, questions, and answers will be part of the final recording. There is CME credit being granted. To receive your certificate of participation, you must do the post-test and evaluation. So please make sure to do that SurveyMonkey at the end. The information will be emailed to you after the conclusion of the webinar, and we will enter it into the chat during the Q&A. So all you have to do is click that link. And the survey will close on March 11th. So you have to complete it by then, and then the certificates will be emailed later that week. We did receive support from the American Academy of Family Physicians National Research Network for this project. And that is funded by the American Academy of Addiction Psychiatry from Substance Abuse and Mental Health Services Administration. And we also received a grant from SAMHSA. We do have accreditation from IFP, from ACCME. For CME, we have AMA PRA Category 1 credit, and should be receiving prescribed credit any day now. Our disclosure statement, IAFP adheres to the conflict of interest policy of the ACCME and the AMA. It is the policy of Illinois AFP to ensure balance, independence, objectivity, and scientific rigor in all its educational activities. None of the faculty, Dr. Bhatnagar, myself, Dr. Rowland, the reviewer, or Kate Valentine have any relevant financial relationships to disclose. We do have an amazing resource that is linked on the IAFP website at www.iafp.com/opioid safety. There's articles, all the mandate information, and all of our opioid education that will be posted there. And then if you don't know about it, there is the Opioid Response Network, or ORN, that's funded by SAMHSA, and that's opioidresponsenetwork.org. It has brought together hundreds of addiction specialists, over 45 national professional healthcare organizations to support healthcare providers, and it's all for free. So you can contact them at that website to see how they can help you and what you are doing in your practices and for your patients. And now on to our presentation. I will turn it over to you, Dr. Bhatnagar.
Thank you. Let me get the screen sharing up. All right, and hopefully you can see my screen there.
Yes, we can see your screen.
All right, great. So thank you for inviting me to speak with you today on a topic that has really allowed me to have a lot of personal growth for myself as an addiction professional. And it's something that I think we often don't think too much about, the proportions of people that are using substances oftentimes are in the background of society, and then in terms of subsections of people who are pregnant and using substances, those are even further in the background sometimes. And so it's an important area because as healthcare professionals, we will intersect with this population in particular, and it's often very, very important to know what it is that you're bringing to that itself. So yeah, as mentioned, I have no disclosures. I have a fair bit of information to get through. We've already talked about the objectives, so I don't need to go through that. I'm going to start off with an image that I want to give a trigger warning perhaps, but I also want people to just reflect on this picture here, and not to bother anyone with it, but it's more because I think the most important thing right now is, as we're talking about this population, is recognizing what our own intrinsic biases are. So as part of this, and I know we're on this webinar where it's hard to have the interaction back and forth with the audience, but just take a moment and reflect on, as this image is here, what are the feelings and thoughts that are coming up for you? If you want to, you could put them in the chat. If you are, if you're so inclined to just do a waterfall of what your reaction to it is. I'll take a moment and pause. I know for me, just looking at an image, looking at this particular image was very challenging initially when I started in training, and my first actual the person that I saw at the inpatient unit on the consult service that was pregnant and using substances, I was surprised by my own reaction and of what I was bringing to it, not just as an addiction psychiatrist wanting to provide the appropriate care, but what I found for myself was a lot of judgment was coming up, and I trained in addiction psychiatry. So this was something that, between wondering how am I able to help this person? That was where I started looking at, first I need to look at what am I bringing, and it made me aware of my own stigma. So as well, and the biases. So I really worked through that, and I use this as an opportunity to remind us that, this is very, very important. The bias is all around us as healthcare professionals. It's around us in society, and the people who are pregnant suffering from opioid use disorder, that can be a real challenge due to the many possibly comorbid conditions and stigma. So I really encourage people to look closely, because this is not Southwest Airlines, and your baggage does not travel for free. So I think as a psychiatrist, I can say that. But in terms of what we do for healthcare, also very important to think about this also from the framework of trauma-informed care. And that is what I want to spend a little bit of time. I'm going to start kind of unpacking this framework and these words that are used a lot. People throw this around, and I don't know that we have really understood from the healthcare perspective what this actually means. So I'm going to take a little bit of time to talk about that first. It is, by definition, it's an approach that's based on the knowledge of the impact of trauma, aimed at ensuring the environments and services are welcoming and engaging for the service recipients and staff. And in order for us to know what this is in practice, I think it's important to understand it a little bit more, that we will have a complete picture of a patient's life situation, past and present, in order to provide the effective healthcare services with this healing orientation. So in brief, I like to think of trauma-informed care shifting the focus from what's wrong with you to what happened to you. And that really allows us to shift from that judgment piece that I spoke about in the beginning to more of a curiosity lens of trying to figure out, okay, we've all had difficult experiences in our lives. What might be the situation that the behaviors that we're seeing can sometimes end up getting in the way of our ability to provide the care that we would like to provide. So how do we shift our own internal focus? And once we start doing that very subtle shift, it becomes easier to notice the benefits of the trauma-informed care. And these have been noticed, through studies that have implemented this, that people are more engaged in the treatment itself. They are more thus willing, because they don't feel judged, they're more willing to come to treatment, follow recommendations. They thus end up with better health outcomes. And in so doing, we're not just taking care of the people, but we're also taking care of the healthcare providers, because we are aware of what we're bringing, and it really allows a deeper connection to the work itself. Ultimately, it can help reduce these avoidable care and excess costs for both healthcare as well as social service sectors. There's often a lot going on that requires a lot of a multidisciplinary intervention. I think of trauma-informed care principles as these 4 Rs: to realize the widespread impact of trauma and understand the paths for recovery, recognize the signs and symptoms when you see it within a patient encounter, both not just with them, but with families and staff as well, to integrate the knowledge about trauma into policies, procedures, practices. So where's the R in that? That's the respond, that you're responding to what's happening in terms of those policies, and then to resist the re-traumatization. So we're wanting to make sure that we are not making a challenging situation worse for the individual. So a good thing to start asking yourself in this process is, where am I? Where am I? And am I just starting to learn about it? So am I trauma aware? And people will say, oh yes, we're providing trauma-informed care, but maybe they're just aware that this is happening and have not yet started to integrate it into their treatment services. There's trauma sensitive. So I think of it as we're on the spectrum of this, right? So trauma aware, reading about it and learning; trauma sensitive, that's somebody is trying to notice the need for the change, kind of prepare the environment to see if it can accommodate some of these policy changes. Responsive is starting to ask the person that's in front of you more about trauma histories, or gather information for the change plan itself. And then trauma informed is where we have actually created and adjusted practice patterns to support people with trauma histories. So in practice, that can look like, for instance, collecting adverse childhood experience scales for each person that you're working with, that reducing barriers to care, focusing on the environment in the waiting room, in the office, to see if there are ways to set it up so that the people who with trauma histories may be more comfortable, which end up making the whole place more comfortable for everyone. And oftentimes this is really hard to do, to get this perspective if you're not, you haven't had those kind of lived experiences yourselves. And so involving other people with those experiences in the planning of how the care is delivered is sort of the pinnacle of trauma-informed care in practice. And so how about your system? Because we're not working, most of us are all by ourselves on an island. We're working within a system. So it's an opportunity to also see, do you want to take this beyond just your own individual practice and beyond to the system itself. So depending on what you start to see around you after this talk, maybe will help you figure out, is this something that makes sense to adjust how we're practicing? And what I like to look at are these opportunities really do make a difference in the healthcare delivery. And so once you start using this, it may be little subtle things, such as the language that you use. And I just want to start with saying your language absolutely does matter. The words that we use when we're talking with people who are using substances or are struggling with mental health issues as well, probably for all folks, but in particular for this population, it's a real and necessary approach to managing specifically opioid use disorder and in pregnancy, because it can change your awareness of your practice patterns. So what does that look like? So in practice, instead of saying, for instance, words like addict, abuser, or junkie, do say person with an SUD, substance use disorder, because it is person first language. So really focusing on how do we reduce the stigmas that we are bringing to the room with our language, with our staff who may inadvertently be saying things that could be traumatizing the individual. We're really trying to make a safe space for the people who are coming in for care. So instead of that the person got clean, you can say the person is not currently using drugs or the person is in recovery. And again, saying person first, but also there's judgment there that implies that using is somehow dirty. And that is something that we hear a lot in our both in the community as well as among people who are coming in for care themselves. They sometimes refer to them to their own practices in this way. And so it's important to specify and be clear that this is a place where that sort of preset stigma institutionally is not going to be present. So instead of saying like the urine was dirty, you would say that the urine showed the presence of, again, it's a value neutral phrase. And this makes it, again, very, very clear to the person that the words you're using are not displaying that judgment aspect. And so relapse is another word that has a lot of connotations, negative associated with it, and a lot of judgment, especially in the NA or AA community sometimes as well. So if we, for instance, say the person has returned to use, it has a fundamentally different flavor to it, and it does not have that judgment piece. And nomenclature also is sort of keeping up to date with the evidence base. We're using the words like replacement therapy or MAT now it was maybe 2016, 2017, we started to shift that to medication for OUD because MOUD is value neutral and more precise. And so we're not saying it's medication assisted treatment or medication for addiction treatment, but MOUD because it is very specific to what it is that we're trying to do. So the point of this is not to make you hyper conscious of the words that you're using or to be worried about being politically correct and what if I say the wrong thing. It's to just bring awareness to do you catch yourself using some of the words that are on the left side in red, and is it possible to just have that moment of awareness to start shifting? How do I think about people who are using substances? And if you're noticing that in your language, then it's oftentimes reflecting if it has been investigated or not, some sort of bias that may exist. So another opportunity to practice this. Specifically with trauma-informed care to women in substance use disorder. And I'll just take a brief aside here to say I'm saying woman instead of pregnant person because the study cited here framed it this way. And the challenges are more complex in terms of the transgender or other folks that are becoming pregnant. So we're saying pregnant person is another trauma-informed care approach. But for the purposes of reviewing this study, I'm using woman here and noticing as I did that in future slides, that's also, I think, more in the interests of brevity on the slide. I have sometimes shortcutted to a woman, but recognizing that that's pregnant person. But if a woman endured sexual abuse as a child, the study was looking at this and found that the woman was 6 times more likely to have opioid use disorder and 4 times more likely to have alcohol use disorder. So this is, and the terminology at that point was addiction. So that's why that's in there that way. But it's something that it's very interesting to think about because it's not causality, is it correlation? We don't know that part of it. We know that there's an association here. So what we do know is that when you see somebody with a substance use disorder, it's a high likelihood that has been some trauma in the past. And so it's another awareness in the back of your mind to start questioning is this a place where I should be looking for, screening for adverse childhood experiences, things that might also be concomitant with that, or mental health issues, for instance, depression, history of trauma, PTSD, anxiety, they travel together often. So in this other study, that more than 30% of pregnant women with OUD screened positive for moderate to severe depression. And then there's also increased rates of postpartum depression coming into pregnancy with that history as well. And we know that if someone is using opioids, there's a high likelihood, again, more of these things traveling together, that they increase risk of use of other substances, including tobacco, marijuana, and cocaine as well. So, and this list just keeps growing, unfortunately, with other methamphetamine, stimulants, fentanyl. We've got lots of nitazines and new substances that are hitting the streets. So the point is, once you notice one, it's good to just keep asking. So how much of a problem is this really? And from the National Survey on Drug Use and Health from 2019, the past year opioid misuse for women that were using in the last year. These are over time, we're seeing that there has been a decrease. However, this did translate to more than 70% of all women with opioid use disorder are of childbearing age, and 4.4% of pregnant women reported using substances illicitly in the past 30 days, so not prescribed to them. And 0.1% of pregnant women were estimated to have used heroin in the past 30 days. So this is all self-report or based on other testing data. The interesting fact on this is that 1% of pregnant women reported non-medical use of opioid-containing pain medication. This is the point I'm getting at here is there are opportunities for access to treatment during pregnancy, and it's only if we're asking and screening that we can find out if they get the treatment they need, because we're seeing here in this last statistic here that 18% of people with opioid use disorder received the medication treatment for it, which is unfortunately, that's in general in the population, but it's much, much lower in pregnancy, and we'll talk about why that is in a little bit. So there are headlines that keep coming out that the use, unfortunately, has continued to go up. And we've seen, this is from the CDC, and it looked at the rate prevalence of opioid use disorder among pregnant women has continued to increase. And you can see the highest sectors are in the Northeast, but in terms of the if you look at Wisconsin, and that's where I'm at, but it's 5 to 8 per 1,000 deliveries. In Illinois, data is not available. So I looked and I still didn't find some in preparation for this talk, but if you all have access to that, I think that would be an interesting metric to update and see. But the main point takeaway here is that the rates, it's happening, it's increasing is what we're seeing, at least in Wisconsin. And the more that we're looking for it and asking about it, more likely it is that we're going to figure out if there is a opportunity for intervention. So during pregnancy, when people have substance use disorder, there's a shift that starts to happen. And people who are using are it's probably not the first thing on their mind is whether or not they're going to become pregnant. And part of this is that women with substance use disorders often experience dysregulation of their menstrual cycle. And part of that is because of the opioid use itself, because we know that the opioids do alter the dopamine prolactin levels in the HPA axis, leading to amenorrhea and these unpredictable cycles. So it can be very hard to know where they are. And it may be that, again, as I said, one of the last things that women are worried about or concerned about. And this menstrual cycle alteration can lead to unplanned and often unrecognized pregnancies. So the consequence of that is they delay initiation of prenatal care. And indeed, we saw this happen in the hospital frequently, where women would be afraid to come in to the hospital or not even even aware, and they were not coming in until they were at 32, 34 weeks or just about ready to deliver. And it was very challenging at that point to try to provide the appropriate prenatal care for them. So the other thing to keep in mind is rates of unintended pregnancy are present in the population as well. It's about half of all pregnancies are unintended. In the people who are getting treatment for opioid use disorder, there's a study that looked at this in 2005 and estimated that about 86% of women receiving treatment for opioid use disorder had unintended pregnancies. So that's just another real statistical reflection of the slide just prior of how this can happen. And so the point is that if you're taking care of someone that you're already taking care of in your office for the treatment of opioid use disorder, and they're in the range of possibility of becoming pregnant, begin counseling early and provide that information about reliable birth control at every visit. So even more important than in usual practice, I think in particular this population, it's good to be screening often and asking regularly about cycles and gravid status. So the effects of, I think of this in the dyad of there's on both the effects of opioids on the pregnancy and the pregnancy on the opioids, and we'll go both ways, but we'll start with the effects of opioids on the pregnancy, on the person who is pregnant. Really what we've seen is high-risk behaviors often accompany opioid use disorder in general in the population. And this also translates to this similar behaviors during pregnancy as well. And so we're talking about increased rates of infectious disease. Some end up being in very dire circumstances and more likely to engage in prostitution or theft in order to be able to sustain the opioid use itself and prevent the withdrawal. So then, and by process, then they can be exposed to violence, and they're more likely to be exposed to violence than pregnant people without opioid use disorder. This is obviously increasing the risk of infectious diseases, as I mentioned, some with IV use as well, and these other high-risk behaviors. So that's another element to continue to be screening for and be mindful of as you're taking care of people with opioid use disorder who are pregnant. Effects of opioids on pregnancy on the fetus are not to be minimized either. There's chronic heroin use and withdrawal associated with fetal growth reduction, placental abruption, fetal death, preterm labor, and meconium passage. So there are consequences, and what we do know from having looked at this now for over a couple of decades here, more than 30 at this point, that withdrawal is directly related to the half-life of the opioid that is used. So the longer half-life opioids are going to have less likelihood of withdrawal, especially if the dosing can continue on a more consistent level, and be less likely to have these deleterious effects on the fetus. So there are mixed evidence of anomalies with prescription opioids. There is some data about codeine causing some of the issues above, but it's, again, as you can imagine, challenging to study. It'd be hard to get a IRB approval for any of this. So part of this, as I have mentioned, is the challenges to getting care once the person is pregnant, if they're not already in care with you before they become pregnant. Some sources of stigma are very much a part of the societal undercurrent that's here, that's making it hard for women to access care, whether they're pregnant or not. I mean, let's just back that up. And it's various treatment for opioid use disorder, but opioid use disorder in pregnancy carries with it its own additional layer of stigma. So pregnant women with substance use disorder feel even more shame and guilt because it's not just themselves, but also the concern of what's happening with the fetus as it's developing. And pregnant women often can fear disclosure to their spouse or partner if they're not in a safe relationship, their family and healthcare providers as well. There's a lot of stigma that comes. Then the other issue that I discussed was fear of legal ramifications, which we have in Wisconsin is definitely a significant barrier here. Illinois law also allows a woman to have an abortion, but to not take drugs while pregnant. The policy that as I understand it from doing my Google searching here, is that it regulates the autonomy of women by allowing them to be found abusive or neglectful if the child's blood, urine, or meconium test positive for drugs at birth. So it's similar in Wisconsin as well, and so we're criminalizing substance use during pregnancy at the expense of access to care oftentimes, and it becomes a significant concern. And it's not just the legal piece, the stigma, but it's also actually these barriers are set up inherently in some ways within our own healthcare systems. So most inpatient treatment facilities for substance use disorder are unequipped to care for pregnant women. And sometimes it's often a hard stop that if the person is pregnant, they're not going to be allowed to stay for treatment. They're in a hard spot because how do you manage the risk for the woman, but how do you manage the risk for the healthcare system? They're not sure what to do. A few obstetric practices specialize in substance use disorder treatment as well, and there are even many addiction practices that are uncomfortable continuing treatment for newly pregnant patient. So the person is stuck in the middle of all of this, trying to figure out, how do I navigate this? The one thing that it's not all gloom and doom, because the one thing that I keep reminding myself is this: when I'm working with this population, in the middle of every difficulty lies opportunity. And that's because in what I've seen in the work that I've done is that pregnancy really enhances recovery. It changes the identity of the woman, this person, and the treatment represents this opportunity. And the studies have borne this out. So after 1 year of treatment, 2/3 of women who entered treatment while pregnant were abstinent, while 28% of non-pregnant women remained drug-free after that year. So that is pretty significant because, and I've heard this from the people I've cared for too, that, that now they're responsible for more than just themselves, and they've modified their behavior accordingly. So given that this is an opportunity, the way to help it be one is to recognize that early intervention is key, and that medications are a crucial part of treating the substance use disorder in pregnancy. And that's really because that will help stabilize the brainstem and allow the person to not be worried about withdrawal, allow them to come back into care. So the other principle that I use is harm reduction, and it's essential, I think, not just to this population, but probably to many other parts of your care, which is summarized as honesty, not perfection. So just encouraging people to be real with you about what's happening and not providing judgment, but rather assistance when you're trying to understand what's happening. And the goal is to continue to provide that support and assistance, prevent withdrawal, and encourage prenatal care adherence, which we can do with multi-specialty care if it's possible, co-located, so that they're not having to make multiple appointments in different places. So it's also going to take a toll on team members at times, and so we want to remind ourselves to take care of each other as well. I look at this as an opportunity for education. Then the name has changed from SUD, from addiction to substance use disorder. And so we think of the dimensions of the diagnosis are now considered as shown here with dependence, of which has tolerance and withdrawal associated with it, and knowing that every human body is capable of dependence. But the substance use disorder is dependence plus these other criteria of impaired control, social impairment, and continued use despite known risk. So we know that there are possible 9 symptoms in the domains of control through DSM-5, and using a larger amount than intended, craving, being unable to quit when you wanted, and then the recovery time. The social impairment was the interpersonal difficulties where it's hard to fill the roles that you have assigned yourself, parenting or work, giving up activities due to use in harmful situations, and use despite known physical or social dangers falls under the use despite known risk. And naming it a use disorder, I'll just say that once reflects the awareness of the power of language to perpetuate stigma. So we can categorize it along the spectrum. And really this looks like this, so that if it's, from both coding, but also just for your own understanding, that it's the more symptoms, the more than 6 makes it a severe category. If you're just in that dependence, that's why you're at risk, but you would not qualify for a use disorder if you're just prescribed and taking medications as prescribed. So that brings us to this understanding, which this is a lot of women say, I don't want my baby to be addicted to heroin. I don't want them to be dependent on it. So is this possible? It is something that, is really important to pause, because the headlines look at this and people see these things that are, again, perpetuating stigma. And the more that you can provide the education that really it's not possible for the baby to be addicted to heroin. There's no substance use disorder. There's no the physiological dependence is there, and the baby may have withdrawal, but it is not going to be able to meet the criteria as we've just laid out. So how do we prevent that from being a concern, the withdrawal part? What we have to consider is opioid maintenance therapy in pregnancy, and the benefits there are quite clearly well studied. We know that when women are using the opioid maintenance therapy in pregnancy, they have a higher birth weight than for heroin use. It treats the urges and cravings, reduces those risky behaviors, which are often done, as I mentioned, to help avoid withdrawal, and improves the quality of life both during and after pregnancy, because now they're connected to treatment and services in a way that they had not been before. There are risks to using opioid maintenance therapy in pregnancy, and with higher rates of neonatal mortality and morbidity than no substance use, but the key is not compared to ongoing substance use. So that's the way to, in your mind, kind of, if you're struggling with, well, I don't want to provide opioid maintenance therapy, it's what you're looking at is balancing the risks of no treatment but ongoing use, which is irregular and going to expose the fetus to more likely chances of withdrawal. And there are risks of neonatal abstinence syndrome, and it's now called neonatal opioid withdrawal syndrome, because we know that there's other medications that also have a withdrawal syndrome for babies associated with it. And so drugs we know with longer half-life have lower association with neonatal abstinence, opioid withdrawal symptoms. So the medications for opioid use disorder that we are familiar with, methadone is the gold standard, has been around since the 70s. It's the best studied option. There has been since 2000 the use of buprenorphine, and we're using that more, studying it more, and finding out that it actually seems to work as well for many women. And reliance on this medication over the last couple of decades has shown us that we have been able to improve the neonatal outcomes. There have been decreased opioid withdrawal symptom scores and increased availability. That's the main benefit to buprenorphine, because it can be prescribed from the office-based setting, as opposed to having to go to the clinic every single day for the methadone due to federal regulations. So there's some controversy about naltrexone. That's the third medication: methadone, buprenorphine, and naltrexone. But there's limited data about naltrexone. So I'll briefly and quickly kind of go through these three medications during pregnancy. As I said, methadone is the most studied and has the most evidence of long-term effects. And this is important to share with the folks you're taking care of, that people were always worried, well, am I exposing the babies and have long-term consequences? There are really no significant cognitive changes in children exposed to methadone that have been followed up to 5 years of follow-up. Beyond that, the studies are still coming in on that, but obviously challenging to tease apart environmental and in utero exposures. And yet when they've looked at it, this is what their conclusion has been to this. Studies do show improved outcomes. People are able to maintain longer time periods without relapse or return to use 6 months after delivery. And if they're stable on methadone, they can continue through the pregnancy. Dose does need to be often increased based on the symptoms because of that increased body weight, blood volume of pregnancy. And buprenorphine in pregnancy, this has been studied and quite well. Andre Jones and her group in 2010 performed this multi-center randomized controlled trial that showed that buprenorphine exposed neonates required less treatment for opioid withdrawal symptoms and shorter hospital stays, less medication for treatment. And as I mentioned, it's more accessible, it does not require the daily office visits. We were using the mono product, so buprenorphine only, not the combined, for a long time in pregnancy because of the theoretical risk of the naloxone and the combination product, buprenorphine / naloxone. And what we are finding, the concern was that it would cross the placenta and it would cause the placental abruption or other challenges, but newer data shows that there's actual minimal increased risk of combination product with the mono product when used as directed. So the point is that whatever happens to be available or preferred during pregnancy is appropriate and acceptable to use. There in Kentucky, this is where some of the data is coming from. The Medicaid just did not allow the combination, the mono product. So the combination product was used, and they found really no increased rates of complications during pregnancy in that population-wide study that was happening. So comparing these two options, the methadone is a full mu agonist, buprenorphine is a partial mu agonist, and they each have their pros and cons. Methadone can take time to get to therapeutic doses because of federal regulations of how quickly they can be increased. It is a Schedule II medication and is really tightly regulated with federal guidelines. And there's oftentimes you need twice daily dosing in pregnancy because of that increased blood volume. With buprenorphine, it's a partial mu agonist, and it can be a little bit more challenging because of that to get people started on buprenorphine. I mean, that's a talk for a different time of how to do the inductions appropriately, but it is a Schedule III medicine made so by Congress back in 2000, and so it's provided at the office-based level, and oftentimes the dose does not need to be adjusted during pregnancy. Naltrexone in pregnancy is the third medication. There's limited data, but it's increasing, and it's both for the oral, but not for the injectable. That's the Vivitrol. So they're only using the oral naltrexone during pregnancy, if at all. And they did find that if the woman was maintained throughout the pregnancy with naltrexone, again, oral, there was no evidence of neonatal abstinence or opioid withdrawal symptoms, which makes sense because naltrexone is an opioid antagonist. There's no difference with anomalies or birth outcomes with similar head circumference, but there was a concerning dropout rate. And this is really the issue, is that in order to get somebody stably onto naltrexone, pregnant or not pregnant, they have to go through an amount of withdrawal. And that is the most challenging part to overcome with people as they are trying to get started on opioid maintenance therapy or medications for opioid use disorder, rather. So there's a Tower study that was, again, looked at this, that had studied women and with naltrexone during pregnancy. They had no relapses prior to initiation, but there was significant amount of support, and there were some people that were in carceral settings as well, so they didn't have much of an opportunity for relapse. So it can be considered if the patient is stable or has comorbid alcohol use, because naltrexone does have an indication for alcohol use disorder as well. But it's not something that I think of as first line by any means. And if somebody's not already on it when they become pregnant, this is not where I would suggest going. So there is this conflicting data about withdrawal during pregnancy. And this was really looked at by people who were wondering about, well, what if somebody doesn't want to stay on medication for opioid use disorder that is an opioid, like methadone or buprenorphine, because maybe their family member is saying they don't want them to be on it, or they themselves have an issue with it. So they, as I said, tried to do this, and they did a systematic review and found, quite honestly, that there's an increased risk of relapse as predicted, because there's, for most people with opioid use disorder without any sort of medication, 85 to 90% of people will relapse within 6 months to a year without any other medication. So there's low completion rate here, and it did not decrease the frequency of opioid withdrawal symptoms for those women who did go through withdrawal, and that was because, as I said, it's really hard to stay away from it. And so it did find that there's minimal risk of preterm labor, so at least there was that. So withdrawal during pregnancy from all ACOG and ACCME, many organizations have come out with a statement, and SAMHSA as well, that withdrawal is really not recommended at this point based on the data and the review of the existent literature. So recommendations are to have the person stay on medications for opioid use disorder during pregnancy since 2020. And it's really not recommended to stop suddenly because of the concern for withdrawal. So how do we figure this out? Now we know a little bit more about opioid use disorder and treatment, but how do we apply it? And it's really in your own settings, I think important to think about screening. And so there's this quick screen, which is a single question screener. And I've got the link there at the bottom, but it's good for all substances, and it's also a good a starting point. But if the answer for any of these substances is monthly or more frequent, then you can ask more detailed questions, and that can look like something as simple as these 4 Ps. I guess I say simple, but in terms of it can be something that you don't have to ask the person. You can have it be on a survey that the person is filling out themselves. So the 4 Ps is parents, partner, past or present. And if there's any yes to these, should prompt further questions and connection to treatment if appropriate. CRAFT has been really tested more for adolescents, but it's effective as well, depending on your population and what you're working with. So I know I'm running a little bit short on time, so I'm going to go through this part. But as I said, the opportunity in pregnancy is that for a lot of women, they have not had access to care until they have become pregnant. And so suddenly you qualify for services that you may not have had. And that can include everything from routine screening and care to dental care, which a lot of women don't suddenly realize, oh, I can actually get care. So I can use this opportunity to access these resources, screen, as I mentioned, for those infectious diseases, repeat the HIV, RPR, and other infectious STI screening in the 3rd trimester, and counsel for substance use and tobacco use, as well as providing that wraparound comprehensive care as it exists. And what does that mean? It's really interdisciplinary care when we can provide it, and it can provide opportunities for them to be connected to other supports and resources through the environment and through their pregnancy, including, if possible, group prenatal care. We know that group support really works quite well in this population. Intrapartum care during pregnancy, during delivery itself, you should not stop the medication during delivery. You can imagine going through withdrawal and well as having labor pains. It just does not make for a good combination, and this is it's unnecessary stress on both the woman and the fetus, and eventually the infant. So what we want to do is have the maintenance dose continued and then receive additional pain relief on top of that. Epidural or other analgesic forms or methods are often recommended. Please avoid butorphanol, nalbuphine, and pentazocine because they are opioid antagonists and can precipitate acute withdrawal. And that is, again, not a situation you want your laboring pregnant person to be encountering in the midst of that. Pain management, postpartum, they did find increased pain scores than peers for women with substance opioid use disorder after vaginal delivery, but the same amount of analgesic use postpartum. And with buprenorphine, they required 47%, about 50% more narcotics after a C-section than for someone who without medications for opioid use disorder. So, and for methadone required 70% more narcotics. So you can see the pain requirements make sense that they would require more narcotics than the person without, and that's just because their baseline is for opioid receptor activity is already higher than if someone is not. So getting MOUD. And then postpartum care for the 4th trimester, that's a concept that I'm hoping people are aware of, and that's that the care of the woman does not end after delivery. It continues for at least the next trimester, if possible, the next year. So follow up, making sure that they're getting into care and maintaining some of that treatment as possible, making sure you're screening for postpartum depression because more than 40% reported symptoms of this. And we want to connect the person with primary care for coordination, and that's really important. If you're managing them anyway through the process, then it's not something that you have to coordinate further. but certainly managing specialist needs. This is a very disturbing image if we unpack it, and if there's a little bit more time later, we can talk about it. But the main point here is that suddenly stopping medications in the fourth trimester is a lethal lethal outcome, has a lethal outcome for these women. And you can see that here in this first, in the lower, the overdose events that are happening both in this months after delivery, and compared to people who are on pharmacotherapy versus not on pharmacotherapy. So the point is continue the medication, and having a newborn is a very stressful experience anyway. So taking away something that might be helping people and not have to worry about withdrawal symptoms is just another way you can help take care of them. So what about the neonatal opioid withdrawal symptom management? If you're called to help with that, or at least talk your patients through it, because I think they might want to know, how is it going to be managed? We like to use a non-pharmacologic approaches now, really looking at, as you know, if needed, we can go through the pharmacotherapy, but how do we want to make sure as much as possible to keep the woman and or pregnant person, no longer pregnant person, and baby together in the same room, and having less intrusive and insertive monitoring. So what we're using now, and morphine is preferred first line if there is opioid withdrawal symptoms, but how do you monitor for that? And it's really the Finnegan scoring was we used to do, which was really intrusive for the baby. But now we're just looking at eat, sleep, and console. So is the baby able to do its three primary functions? Are they able to eat? Is the baby able to fall asleep and be consoled if they're upset? If the answer to those questions is yes, then that goes towards the fact that there's less for us to worry about there. It's important to involve parents in the monitoring as well. In this image here, we're talking about breastfeeding and nursing is not contraindicated. A lot of people think that they should not be nursing if they have been on medications for opioid use disorder during pregnancy, but in fact, it helps with mitigating any of the opioid withdrawal symptoms as long as other behaviors are not a contraindication in and of themselves or infectious diseases. So it also can improve the bonding and the consoling piece. So safe sleep we talk about. And then the other thing that I want to not overlook, which often happens, is that nicotine has been most closely associated with the neonatal abstinence syndrome, even more so than opioids. And so the presence of it is fascinating to me, that we often forget about screening for a nicotine use disorder because we start paying attention to the things that are getting more screen time. And so it is certainly something to keep in mind. That so in summary, I'll just pause here. Medications for opioid use disorder during pregnancy is absolutely recommended, and the harm reduction approach that I've talked about, honesty, not perfection, is a great place to start working on the stigma approaches for yourself, or anti-stigma approaches. Recognizing that, as I've discussed here today, that treatment really represents an opportunity for improvement in many areas of the person's life. And then, so I'll just leave you with, are you ready to start using some of these trauma-informed care principles in your care for this population that otherwise may not get the treatment that they need and or deserve? And what I like to remind myself each time I go into a person's room, and or working with someone where I know that they may be struggling and I may be struggling, is that maybe this time we'll be able to get it right. So with that, I'll pause and see if anybody has any questions.
There are no questions in the chat. If anybody has any questions, please put them in the chat now. I do have one question. Do you recommend pre-delivery, if it's available, getting an anesthesia consult, just in case you end up needing a C-section?
Absolutely, yep. And I think the opportunity for the person that you're taking care of to know that if it would be something that you would you might do for anybody else, right? Like if you have a person who's not using substances, do you give them a pre-anesthesia consult? You can think about it that way. You can also say, okay, well, there's a possibility, and the woman may have a lot of questions of how is my pain going to be managed? What is, it could be part of the birthing plan, actually, of working out these details beforehand. And having that pre-anesthesia consult is a great idea because it also lets the person know that you're really thinking about what is, you're working with her to make sure that there is less likelihood of her having the most uncomfortable experience. So whatever we can do to help manage the anxieties around this experience, and knowing that there are a lot of unpredictable things that will come up, that, the more you can plan for, the more it's going to be allaying fears both for her and also for you as a provider, that you're not trying to do this without more specialist support.
So where I've worked, that hasn't been available, having the anesthesia consult for pregnant patients. But I wonder if in our MOUD clinic for pregnant patients, if that might be something worth discussing with anesthesia about making available.
I think it's a really good idea to at least start the discussions of what can the system provide, because
Right.
as soon as they have a challenging experience in the delivery room or afterwards, and if the person is so uncomfortable that they are going to be causing, again, it's the reactions from the staff that often get the feedback and the changes to happen. So that is certainly something that can reduce the likelihood of challenging postpartum experiences as well.
Thank you so much. I do have a couple slides to share in our last 2 minutes.
Okay.
So I still didn't see any questions in the chat. So please, if you have any, let us know. A little bit of additional information. If you need anything from the Academy, please reach out to Sarah. Her email's on the screen. We put the survey link in the chat, so please make sure you click on that. It will also be emailed to you. There will also be an ORN eval to help improve future trainings, and remember to fill that out by March 11th in order to get your CME credit. Please consider helping out our Academy and leaving us a Google review. We would really appreciate it. I'm going to check the chat one more time for any questions. I don't see any. Thank you all so much for attending, and we will see you again soon. Thank you. Have a great day.